Gives me the pleasure to introduce Stephanie Snow, who is a research fellow at University of Manchester. She has a number of interests, many of which are outlined in the brochures. I'm not going to go into it in order to give her more chance to talk and more chance to for us to ask questions of her. She has great interest in anesthesia, and that's going to be related to her talk today. And the only question perhaps she could answer, if I can ask a question before she actually starts, is whether she's related to Dr. Snow, the anesthetist in England.
Many of you today in the audience have actually got direct experience of proposing operations to patients, so discussing the pros and cons, gaining their consent to the procedure. And I guess many patients will raise concerns about the anaesthetic itself, perhaps the risk of post-operative vomiting, possibly of losing teeth. But however substantial their concerns may be, I think it's pretty much impossible for us to imagine a surgical procedure going ahead without some form of anaesthetic. And that's because we consider it as essential to prevent physical suffering, both within and in many arenas outside the operating theatre. And the ways in which we think now about surgical pain were formed during the mid-19th century, specifically when the discovery of anaesthesia catalysed fundamental reconfigurations in thinking about pain, death, and the value of life itself. So what I plan to do over the next 40 minutes or so is to reconstruct the process through which surgical pain was recalculated from being a necessary evil but purposeful to a physiological risk. So I want to begin by talking broadly and quite shortly about some major reconfigurations that happened between the 1790s and the 1840s. And these shifts are of critical importance because what they do is help us understand why, although contentious, anaesthesia was thought to be viable in the 1840s in a way that it was not thought to have been viable in the 1790s. So moving first onto understandings of death. The understanding of death as an absolute in terms of thinking about it as an event in which there is no possibility of intervention starts to shift in the 1740s. So it leads into developments like resuscitation, reviving people after they've been drowned. By the 1840s, it is understood as a process in which intervention is possible. So, for example, asphyxia may not always be fatal. A patient could be resuscitated. In terms of sensibility and the way in which the nervous system was understood, sensibility in the 1790s was understood to be integral, not just to the nervous system, but actually integral to motor function itself. So in terms of disassociating the sensibility from the motor function, that was just not thought to be possible. And obviously, if there was any sort of impact on suspending sensibility, then that would have fatal consequences for life itself. But during the 1790s to the 1840s, there's a lot of work that starts to be done on the nervous system, and the thinking that actually it can be understood as different systems and the functions separated out makes it become possible to think that actually you can have a system whereby you suspend the sensibility, but you can keep the other sort of functions ongoing. And during this period, the whole thinking about pain starts to shift. We've got very strong evidence of a very growing social antipathy to pain through the dramatic increase in the use of opiates from the mid-18th century onwards. And we can tell from casebooks and journals that doctors start to begin to use opiates to help patients who are dying when they have pain. They're sometimes used in childbirth, they're used for a lot of sort of chronic conditions, but in terms of surgery, they're used very little. And this is because at this point, surgical pain was understood to be a physiological benefit. So the way in which the dynamics of surgery were understood was that surgery acted as a depressant upon the body. Pain was a stimulant, and therefore, whilst the surgery was depressing the body, the pain was the artifact which would sort of push the vitality through. Nevertheless, there are lots of sort of shifts that start to suggest that actually the idea that pain is actually not necessarily a benefit but perhaps a risk in itself start to come through. And I'm not claiming that these shifts really explain exactly why anaesthesia entered medicine when it did, but certainly they provide the intellectual and the practical context within which we can sort of understand it. The big shift in terms of surgery is the actual emergence of what was called conservative surgery in the 1820s, and I want to move on to look at that in more detail now. So whereas in the 1790s, surgeons practicing had understood amputation to be the safest form of intervention because it was the shortest, it was fast and effective, from the 1820s there was a shift to preserve limbs and tissues. So for example, rather than simply amputating a limb, it would be excising diseased or injured bone and tissue. It became very much the mark of a modern surgeon. So elite surgeons such as James Syme in Edinburgh, William Ferguson in London, pioneered new procedures such as the excision of the foot. You can see an illustration here from Hewitt in Paris. And one of the arguments was that this sort of surgery actually gave the patient a much more functional outcome. So rather than lose a whole limb, they might actually have save, that they're walking. But from a patient's point of view, the consequence of this development in surgery was that it prolonged considerably the period of suffering. So whereas an experienced surgeon would amputate a limb in a matter of seconds, an excision of a foot could take 20 minutes, 30 minutes. And despite the utilitarian advantages, there were consequences for the patient experience. But if you look here at this quote from Robert Liston, who was a surgeon in London in the 1840s, he's promoting very much conservative surgery as a utilitarian process, so that it is of benefit to the patient in the long run. On the other hand, he has a very critical awareness of the pain, and therefore in talking about the way in which the incision should be carried out, it's with attention to the effect that that will actually have upon the patient. But what's also clear from surgical reports and case studies of the time is that with the emergence of conservative surgery, there came a new strategy from surgeons which sought to help patients cope with the pain of surgery through moral fortitude and ideas of self-control. So whereas in earlier generations, surgeons had specifically encouraged patients to cry out during operations because they saw it as a way of expelling the pain, just as you would use purging or bleeding to expel unwanted or excessive fluids from the body. One surgeon, Henry Klein, in the same year as this quote from Fanny Burney, whose patient was undergoing lithotomy, told him specifically to cry out because that would stop his energies being depressed if he was trying to control his reaction. And this quote from Fanny Burney describes her experience of a mastectomy. And again, the surgeon was very much sort of supportive of her actually screaming and actually getting rid of the pain through the vocalization of it. But from the 1830s onwards, surgical textbooks talk about the preoperative meeting between surgeon and patient in very different terms. They talk about it as a key opportunity for the patient to mentally prepare for the surgeon to prepare the patient to meet the evil of the operation. And Thomas Curling, one surgeon at the London hospital, remarked that it was not uncommon for operations to be abandoned, and this quote would be to the impatience and want of self-control of the sufferer. So this new stress upon patient self-control, patient fortitude, is quite evident when you sort of track back through operations reports. One correspondent wrote to the Lancet in 1840, quote, When a person chooses to die rather than submit to an operation, it is generally an evidence of deficient fortitude. So there was this whole cultural shift going on that actually in a previous period it was okay to vocalise pain, but actually by the 1830s coming up to 1840s, self-control, fortitude, moral control of pain was promoted. Many surgeons experimented with different methods of trying to alleviate the pain of surgery. James Wardrop, who is quoted here, often created a state of low pulse and intermittent consciousness through bleeding the patient prior to the surgeon. Other patients developed clamps that would be put on prior to an amputation, but actually patients believed that that affected a worse pain than the amputation itself. And then the early 1840s, surgical innovation is really sort of increasing apace, and there starts to be surgery for a remedial rather than simply life-saving reasons performed. So, for example, between September 1840 and December 1841, in the Lancet there were accounts of new operations for conditions such as stammering, squinting, clubfoot and cataract. And it can suggest that contrary to a lot of historical interpretation, surgical development was not dependent upon anaesthesia, certainly in this period. Nevertheless, in practice, the risks of infection, blood loss and mortality remained very high, and operations were the last resort of surgical practice. Most surgical patients were treated with therapies or local applications, things like poultices to reduce inflamed joints or bandaging to heal fractured or diseased limbs. And the evidence suggests that in the period directly before the introduction of anaesthesia in 1846, justifying the risks of surgery were unequivocally established as it being a means of saving life. So it's quite a stark calculus that's being used. And this is borne out in the very low numbers of operations that were performed. Each London hospital held only one short elective operating list per week, rarely were there more than 2 or 3 major operations performed. Acute surgery was undertaken for only the most severe trauma cases or conditions such as strangulated hernia. You can see here some of the figures that I've picked out from operation records. So at Guy's, 2 amputations, 2 lithotomies per month. The mortality was high. 4 out of every 7 patients died at Guy's. For thigh amputations, these were from University College London, 6 out of every 10 patients. Lesser operations such as the amputation of fingers or toes, smaller tumours, cleft palate or hair lip repair, these are undertaken on the rationale that if surgery was undertaken at that point, it would actually prevent consequences of sepsis or infection developing, which could actually create greater problems. And so operative mortality was high, although there was an overall drop in hospital mortality during the first part of the 19th century. In terms of operations, the mortality did not change much during this period. And these rates in London seem to be matched in other figures for the UK that I've found. So, for example, there was a Liverpool surgeon, John Holton. His statistics of 1843 revealed that 1 patient out of 6 died after a leg amputation. Arm amputations resulted in 1 death out of 18 patients, and 1 in 4 patients treated for hernia died. And in each of those cases, the cause of death was tetanus or gangrene. Therefore, the infection was a significant factor. So, in view of these figures, it's very uneasy to understand the stress that surgeons placed upon the process of assessing the risks and benefits of each operation. So I want to talk a bit more now about the process of decision making, because I think that's very interesting. And there was a rigorous evaluation, not just of the risks, but also the propriety of each operation before proposing it to patients. And surgeons frequently would discuss cases with their peers. So when William Lawrence, who was at St Bartholomew, suggested that the entire breast of a patient should be removed, he noted in the notes that the hospital surgeons, his colleagues, had supported the propriety of that operation. You'll see the quote here from James Simpson. He was an Edinburgh physician who was to discover chloroform in 1847, But this was written in 1845, and it expresses very clearly the professional dilemmas faced by doctors considering operations in cases such as ovariotomy, where there was immediate danger to the patient's life. So it was this real sort of mixture. It was the sort of personal responsibility, it was the public responsibility, it was the evidence of outcome. And it's very interesting that in this period, just prior to the introduction of anaesthesia, the humanitarian aspect seemed to be highlighted significantly. So it's almost as though surgical pain is becoming more and more of a problem as the 19th century is progressing. Patients often took time to come to a decision, and they do not appear to have been unduly pressured. Benjamin Brodie said the patient must decide for himself. Robert Liston confided to a colleague that he refused to try to persuade the patient because it was too serious a matter. So there seems to be a very clear practice where, you know, the choice was with the surgeon, the patient. The recommendation might be made, but the patient definitely had the veto. And there is evidence that patients were very aware of this freedom, both to exercise their veto and to exercise choice. And there are lots of examples of the same patient going round several London hospitals to get different opinions before they decide which surgeon they might go to. In 1846, there was a patient who had ulcers on his arm, and he had actually been admitted to Guy's, King's, Charing Cross and the Metropolitan hospitals. And the very first hospital he went to, Bransby Cooper, the surgeon there, told him that the only way in which he could save his life would be through amputation of the arm. Though because the patient refused to accept that, he continued to go round and try different surgeons. It also seems that many more operations were proposed to surgeons than were actually performed. So, for example, the annual report of the Edinburgh Eye Infirmary in 1836 had 2 columns, and one were number of operations performed, the other was the number of operations recommended but not consented to. And you find the same things in surgical records at Guy's. The 1845 and 46 records show many instances of where patients have refused operations that they've been offered. So therefore the whole process of gaining consent was very much negotiation and collaboration. There was no element of domination from this evidence that comes through. And surgeons did seem to be working within what we might see as a peer review system, so colleagues were involved in decisions too. But as I've said before, by 1846 and the introduction of anaesthesia, not only was there a social antipathy to pain, but and that was really demonstrated through the increasing use of opiates, but the new anatomical and physiological constructions of the body showed that it was perfectly possible to sustain life in a body that had no sensibility. Surgery was developing new techniques and offering new possibilities for improving patients' conditions, but the lack of an effective means of surgical pain relief seemed to create a context in which surgical pain was becoming a bigger and bigger problem. So I want to turn now to the introduction of ether, whose anaesthetic properties were discovered by the Boston dentist William Morton in 1846. I'm not going to talk about the discovery of anaesthesia in specific detail, but I want to move straight on to the uptake of ether in surgery and the ways in which it impacted on surgical practice and culture from the outset and drove the critical reconfigurations that I've been talking about around pain and risk. In terms of understanding exactly what happened when ether, the news that ether could induce insensibility during surgical operations arrived in Britain, we have excellent records of everyday practice through the casebooks of Jon Snow. At that time, in 1846, he was a general practitioner in London, but he was a very strong proponent of scientific medicine, the scientific medicine that George was talking about earlier this morning. And he had a very clear idea of the way that medicine should be performed in using the science, the chemistry, the physiology to underpin what was actually happening in practice. And from his casebooks and his published writings that were in the medical journals of the time, we have records of over 4,000 anaesthetic administrations he did between 1846 and 1858 when he died. And this has really allowed us to reconstruct the fine grain of his everyday practice. And it gives us a very clear idea of sort of, how the debates were shifting, what his practice actually was, the hospitals he worked in, the surgeons he was working with, the procedures that he was undertaken. And although the focus is very much on London and Snow's practice, from comparisons available from other countries and what was happening there, Snow seems very much at the forefront. So I think we can assume that this was sort of the spear guard of the whole uptake of anaesthesia. So in terms of the arrival in the UK, letters were sent from the Boston medical community to friends and colleagues in London, and they arrived in the middle of December 1846. And by the end of January 1847, so that's a matter of 6 weeks, all the major London hospitals had trialled Aether, and so had many provincial centres. There are records of at least 80 surgical operations using Aether during these weeks for major operations such as amputation, lithotomy and hernia, as well as the removal of tumours, toenails and teeth. So when you think back to the numbers of operations before Aether and how low those were, this suggests a significant amount of activity. Apart from the obvious humanitarian benefit of saving pain, in terms of the surgeon, this could often sort of transform the procedure. It could make it more efficient, it could save time. And this quote here is from William Lawrence, who operated on a patient at St Bartholomew's to remove a diseased eye, and really marvelled at the improvement that Aether brought. In terms of the effect on the patient as well, Lawrence recorded that the patient slept well the night before the operation because his mind was tranquilised by the belief that the new process would lessen or prevent the pain. And Lawrence compared this operation to a previous one he had done when the patient had suffered intensely and, quote, writhed in agony, not being able to control himself. Lawrence also noted that the insensibility produced by Aether had saved 20 minutes operating time. So Aether affected relaxation on the muscles, so it made it possible to reduce long-standing joint dislocations. A strangulated hernia could be remedied without operation under Aether, and Robert Liston inserted a catheter in the bladder of one patient under Aether without having to cut the perineum. Children seemed to respond particularly well to its effects, and some of the first patients to be operated on were children. And yet Aether inhalation was not pleasant. Patients complained of its pungent smell, they felt suffocated, there was irritation to the throat, but the vast majority were prepared to trade those discomforts for the benefits of painless surgery. And the first patients who were given Aether at King's College by William Ferguson were chosen by him precisely because their fear of pain had caused them previously to refuse operations. So, for example, a middle-aged man who needed a circumcision was very averse for fear of pain, but agreed to have it done under Aether. And I think the sort of patient keenness and appetite for Aether is significant. And this example here is of a patient who wanted some teeth taken out, but had gone to visit a dentist, asked specifically to have it done under Aether. And therefore, sort of, the conditional use of pain relief then allowed the operation to sort of go ahead. And it gives us a very clear sense, I think, of how pain had become such a barrier in terms of, surgeons had the techniques and the ability to actually effect these operations. Patients were sort of, keen to have the improvements in their health, but pain was the chasm in the middle. But although Aether resolved the humanitarian conflict of surgery, it also created new problems. And this was largely because surgeons often found it difficult to induce a full anaesthetic effect. And with the consequences of Aether, patients became inebriated and disinhibited. So there were lots of tales that abounded in the journals of patients propositioning surgeons and dentists under Aether, One respectable solicitor asked his dentist to dance the polka with him. And lots of cartoons that were really sort of satirised Aether's powers. So, for example, here, the idea is that the head on the left is the ugly head, the pretty head on the right, and the transformation can be affected by Aether. But in terms of actually bringing Aether into the operating theatre and using it to effect anaesthesia to carry out a surgical procedure, it created a lot of complicated issues. And as I said, the difficulties seem to have been caused because the first inhalers were designed using glass flasks. This didn't seem to take into account the requirement for Aether to be vaporised in order to sort of release its anaesthetic properties. And this is where Jon Snow's approach is markedly different, because early in that December period, when news arrives in London of Aether, he goes to one of his dentist friends and he watches a tooth being taken out under Aether. And as soon as he's done that, he doesn't go and get Aether from the chemist and find a patient, as most doctors did. Rather, he obtains Aether and he goes back home and he sets up a whole series of chemical and physiological experiments. And what he wants to establish are the scientific principles for Aether administration. So, for example, he establishes that the degree of anaesthesia is determined by the concentration of Aether in the blood, and that the temperature determines the concentration of Aether in the vapour. And therefore he designs an inhaler which uses a water bath that can then control the strength of the Aether vapour, and defines essentially a method for sort of quantifying the dose. And he relates this through animals' experiments into the anaesthetic process, which he terms as a series of degrees. So the first degree is inhibition, but then gradually, as parts of the nervous system become suspended, it gradually results in a body which is alive and breathing, but actually in which sensibility is suspended. Nevertheless, by the spring of 1847, two fatalities start to cast doubt on Aether's viability. The Medical Times writes, "Should the great discovery of the age be abandoned?" It talks about numerous serious accidents of less fatal character. And in places in Europe, Zurich, for example, Aether had been banned as being too dangerous. But although Aether remained in use in large centres like London and Edinburgh and in some communities, its use had tailed off. There had been this huge sort of uptake and experimentation for the first few months, but then the difficulties of actually effecting successful anaesthetic administrations meant that a lot of surgeons gave up using it in practice. And Snow wrote that this was because they found it impossible to push the Aether beyond the struggling excitement stage. Because they weren't conceptualising Aether as an anaesthetic process and the inhibition was simply one stage, they were looking at it as a therapy, and therefore if patients were becoming disinhibited or overexcited, they would then stop because they felt to go beyond that stage was dangerous. So it's very much about two very different frameworks being used to understand and conceptualise Aether at this time. And I think it is possible to imagine that at this point Aether could have remained as a marginal technique. So its use might have been confined to communities where individuals had effected successful ways of practice. However, James Simpson, the Scottish physician and obstetrician, discovered chloroform in 1847. Again, this was totally different to Snow's approach. Simpson was a great advocate of Aether. He used it particularly for difficult obstetrical cases. And he went to local chemists, asked them to send in agents that they felt might perform in the same way as Aether. And he had two medical assistants working with him, and he would get them to try these agents out. And if they found one they thought might be viable, they would all try it after dinner. Hence the picture. And chloroform was immediately taken up. Again, there was a real appetite for it. And it was found to be able to be administered very quickly and very easily. It was much more pleasant than Aether. It was easy to breathe. Surgeons found it very effective. But within weeks of its introduction, unlike Aether, which is actually proved fairly safe, it showed that it had the propensity to cause many fatalities, and critically without warning. And this gave rise to a strong debate, particularly between London and Edinburgh. It became polarised in terms of the mode of chloroform death. Snow's argument was that if chloroform was administered with an inhaler according to his set out of the anaesthetic process, and it was not administered beyond a safe dose, then life was protected. It would not cause death. And that chloroform death was caused by overdosage. And this was because most patients, most surgeons, used the method shown in the bottom picture here, which was promoted by Simpson, of just dropping chloroform onto a cloth and putting it over the patient's nose and mouth and breathing in. Simpson's argument was that actually chloroform was a form of asphyxia, and it was the respiration that was being affected through that. And again, this comes back to what I said a bit before. The differences can be understood as different ways of thinking about the body and thinking about the anaesthetic process. So, for example, Snow was seeing it very much as a process within the new scientific frameworks. He believed that the quantification was the way in which safety was sort of guaranteed. Other practitioners were using it much more in the classic model of therapies, and you give the patient the dose, and it depends on the patient's individual constitution and context as to how they respond. So let's focus on more detail now in terms of how the risks of anaesthesia were being calculated during this period and the consequences of surgical risk assessment. As we've seen, the idea of sort of, balancing the risks and benefits of medical intervention was not a new phenomenon at this time. It has a history which we've heard more about this morning. In terms of Aether, the highest risk was really thought to be moral because of the stimulating and disinhibiting patients in the operating theatre. The physical risk of asphyxia was there, but in reality very few deaths were directly attributed to Aether. And so for this reason, the arguments around, the need to sort of protect patients from asphyxia with Aether weren't really made. It was far more about the moral and social risks. Advocates like Snow and Simpson, who constructed the pain of surgery to be an inherent risk of itself, took the view that it was a very simple calculation. Anaesthesia's benefits were not just humanitarian, but they could be quantified clinically, because by removing pain, they were removing a physiological risk, and this was a risk that would impact upon the surgical outcome. Simpson compared mortality rates pre and post anaesthesia. He calculated that in British hospitals, pre-anaesthesia mortality rates for amputations of the leg, thigh and arm came to 29 deaths in every 100. He then compared these to post-anaesthetic rates, and he found that the mortality rate had dropped to 23 deaths in every 100 cases. So his argument was that 6 lives out of every 100 cases are being saved by anaesthesia, and therefore this was the proof that it should be brought into practice across the board. But most doctors found that it was very difficult to do that sort of stark evaluation. They relied far more upon their own experiences than upon statistics. Chloroform, again, really sort of exacerbated the risk debates, because from the beginning, within weeks of its introduction, there were fatalities in which the cause of death remained uncertain. And, the understanding as to what was actually causing death, was it overdosage, was it poison, was never resolved in the 19th century. It was not until 1911 that it was found that actually a low dose of chloroform could induce ventricular fibrillation, which accounted for the cases in which surgeons felt they hadn't overdosed with chloroform, yet the patient had still died. So in terms of sort of evaluating risks, Snow had absolute confidence that anaesthesia should be a universal practice, and that's because he saw it as a chemical process which was predictable. The physiological effects produced by chloroform and ether were predictable, and as long as the administration was managed and the dose was quantified, then that scientific framework made it a safe practice. He also, I think this quote from Snow on the right is actually very revealing of the way in which doctors were having to make calculuses of risks on subjective appearances. Again, you know, the sort of in terms of the way in which they were thinking about evidence, they had the appearance of a patient, you know, apparently sort of on the verge of death, and yet they're having to reinterpret that is a safe bodily condition in which they can sort of be retrieved from, you know, and Snow's saying, you know, the appearance would be truly alarming, but we know it's an agent that will be flying away every moment in the breath without any permanent trace. But actually, if you're interpreting ether and chloroform in the old models of therapies, then that conception is not there, and therefore it's much harder to see that the risk is not a significant factor. And here again, we've got a very clear example of the way in which Snow is both evidencing and constructing pain as a physiological risk. He was tracking here what was happening to the patient's pulse during a lithotomy when chloroform wasn't being used. And as you'll see, he says, you know, the pulse became uneven, irregular, intermitting. I could not count more than 3 or 4 beats at a time. Occasionally, when the pain seemed greatest, the pulse was altogether imperceptible for about 5 seconds at a time. And therefore, from his point of view, you know, that physiological response to pain was a very clear argument for why pain should be suspended during operations. And again, one of the issues with anaesthesia is that often patients were very fearful before inhaling ether or chloroform. And some surgeons would refuse to let them have anaesthetic because they argued that if a patient was fearful, that was actually going to exacerbate the risk of having a bad outcome. But Snow's argument was that actually once they started to breathe chloroform, the pulse slowed down. It took away the fear. Fear was in the mind, and once the anaesthetic cut off the mind, then the body returned to a safe state. And this is a very sort of clear quote again from the London Medical Gazette about how it was being understood, how anaesthesia was being positioned like any other therapy, which was mediated by the peculiarities of individual constitutions. So again, it's this balancing between sort of experiential knowledge coming from direct practice, from experience, and actually sort of external sort of evidence and scientific evidence that's coming together. And what this produces for patients is a huge variety in surgical attitudes to the risks of anaesthesia. And therefore, in the same hospital, there can be very different patterns of practice. So although, for example, in St Bartholomew's in 1850, the governing board was in favour of anaesthetic, it provided funds for the chloroform, the equipment and the staff, but actually the decision on the use of anaesthesia in the operation in the hospital practice was determined by the surgeon. And so you get a very arbitrary approach, as you'll see here. 26 operations were performed during that year. You know, one surgeon used it 67% of times, Lawrence only used it 36%, Lloyd didn't use anaesthesia at all. So a huge variety. And it's quite easy, I think, for us to sort of judge this practice as quite random and disparate. But actually, it grew out of this very strong conviction that anaesthesia was not a predictable process, that each inhalation had the potential to end in death. And surgical attention remained focused on the preservation of life, even if that meant suffering the pain of operations. And there's a very nice example of the way in which perceptions of risk determine surgical practice and the use of chloroform, because during 1854 in London, there was a cluster of 7 chloroform fatalities, all in the London teaching hospitals. And this seems to create a context in which chloroform seems to take on new risks. And by analysing the administrations in Snow's casebooks and then comparing them to data from some of the other London hospitals, we can get a very clear view of this dip. You'll see that sort of the figures from 1853 down to 1854 dip, and then they start to sort of take up again. And this becomes much more interesting when you actually look at which operations are not going ahead. So for example here, what I've done here is these are all the anaesthetics that Snow gave over the period, and each line is the sort of patient they were. So he did operations within hospitals and he did operations in private practice. And you can see here that the yellow and the blue lines, which are the hospital and the males and females, the use of chloroform diminishes, is much lower anyway than in private practice, but actually there is a diminishment that you don't get with the private females. That's the turquoise line. So in private practice, actually the crisis of confidence in chloroform doesn't seem to affect female surgery. It affects male surgery. There's a dip between 53 and 54 for private males, but not for private females. And this is very interesting because, of course, it ties into ideas about females having much more sensibility. You know, the idea of that anaesthesia can protect them from the pain. They have more need of that protection for that. And what these figures also sort of show us is the way in which it's who's really sort of driving the decision making around the use or the non-use of anaesthesia. So, for example, in hospitals in London at that time were mainly for the poor and the working class, and surgeons have very much make their decisions about, you know, the operations they offer and how they get done. Whereas in private practice, patients have a free market, and therefore if they go to a surgeon and they decide that an operation is inevitable and they ask for chloroform and the surgeon says no, well, the patient has the freedom to go to another surgeon. And I have done some analysis, I haven't got it on the slide here, but there were surgeons that Snow worked with who would do exactly the same operation in the hospitals and in the private practice, and chloroform is used in the private practice but not in hospitals. And again, it's this sort of mediation of risk. You know, how do you balance risk? How do you make the decision whether or not you subject the patient to that risk? And this is a quote from the Lancet, just at the time when this idea of the crisis of the fatalities is starting to sort of take shape. And you will see that even by 1853, 6-7 years after ether and chloroform, the Lancet is still arguing, that the pain of an amputation is not necessarily sufficient to justify the fatal risk in such a subject. It was better that 1,000 individuals should each bear, when necessary, the momentary pain of amputation than that one of the 1,000 should die in an attempt to remove this momentary suffering. Nevertheless, the fact that the use of anaesthesia in private practice continued to thrive despite this crisis period suggests that from the patient's point of view, the fear of death, even for a tooth extraction, was stronger than the fear of pain was stronger than the fear of death. And it's quite remarkable, I think, as well, that during this time of heightened awareness of risk, when surgeons were clearly curtailing their use of chloroform, that in the UK there was no return to ether. In the northern states of America and other parts of Europe, most surgeons had returned to ether by the early 1850s. They felt it was a much safer anaesthetic. And yet in the UK, it had a predilection for chloroform that persisted throughout the 19th century and into the 20th century, despite this increased risk. Now, the medical malpractice context is different, and I think that was a factor. Because in America from the 1830s, there was a growing incidence of medical malpractice suits. And I think surgeons there were probably far more alert to the idea of risk, and they tailored their practice accordingly. For example, one American surgeon in the 1870s said that there's no way he would use chloroform, because if the patient died and he was called to court, he would have to defend why he was using a risky anaesthetic when ether was available, which was seen as a much safer one. But British dislike of ether persisted, and surgeons continued to give priority to chloroform despite the risks that were in practice. By 1856, the London crisis of confidence in anaesthesia is over. We can see from figures at King's College and Snow's practice that the numbers keep sort of increasing again. And in part, this increasing confidence had been fueled by the successful use of chloroform during the Crimean War. At the outset, in 1854, Sir John Hall, who was the principal medical officer, had cautioned army medical surgeons that they should be really cautious about using chloroform. He said it was much better to hear a man brawl and shout lustily during the amputation than to sink under the effects of chloroform. And again, he was talking about pain as a benefit. He said, the smart of the knife is a powerful stimulant. We don't want to see the man sinking silently into the grave. So again, the idea that pain in surgery is performing a vital function is still going strong at this time. Therefore, if you take the pain out of the surgery, you're actually increasing, not decreasing risks. Nevertheless, despite Hall's memorandum, many army surgeons persisted in using chloroform, and over the period of the war, it became reconfigured as actually a benefit. So even for shocked patients, those who've been very traumatised, and we spoke earlier that there was often a debate as to whether operate quickly or leave it because of the shock on the system. The idea came through the experience of the Crimea that actually chloroform was overall a benefit. And it's very interesting when you see at the end of the Crimea and the army surgical textbooks start to be rewritten, chloroform, which in 1854 was a no-no for severely injured patients, actually becomes far more a norm of practice by the 1860s. And so, although the majority of surgeons did not initially share Snow's view that anaesthesia decreased the physiological risks of surgery, by the late 1850s the balance of opinion had changed. And it suggests that the view of anaesthesia as a process that could induce insensibility but without interfering with circulation or respiration was becoming more common and was driving the adoption of anaesthesia as a norm rather than the exception in surgery. And we'll see here the way in which Snow argues about pain. And this was his immediate construction after his experiments with ether. But it had taken a period of sort of pretty much 20 years for that to become far more widely adopted. And by the 1860s, the practice of selective anaesthesia, and in terms of who gets it for what and who makes the decision, really starts to diminish, and pain relief is used for most major operations in major centres. Very hard to generalise at this stage, but there's a definite sort of pattern that's emerging, particularly in London. Chloroform fatalities continue to provoke medical and surgical and public concern throughout the 19th century. But nevertheless, there seems to be a common view that it offers more benefits than risks. And we get quite a sort of clear view of this because in 1862, a chloroform committee was set up of the Royal Medical and Chirurgical Society to look at the different effects of anaesthesia. And that focused very much on questions of how anaesthesia could be made safer, rather than whether or not it should be used. So the way in which it was framed had changed significantly during this period. And there's no doubt that anaesthesia brought substantial change to surgical practice. Patients were far more willing to consent to operations, and surgeons were able to offer much more complex and protracted operations. Not that they developed their technical skills after anaesthesia, they had already got them, but they were able to sort of put them into practice in a way that hadn't been possible before 1840s. And in parallel with this shift as well, there was a notable increase of operations on women and children. Children, particularly because anaesthesia solved the problem of control, and therefore they could undergo various procedures. And again, the widely held belief that female patients were much more susceptible to pain encouraged surgeons to offer operations to female patients. So really, by the time we get to the 1870s, there are very few surgeons who are prepared to perform and few patients willing to tolerate surgery without anaesthesia. In Guy's Hospital, in the surgical records from 1872 to 1874, less than 1% of patients refuse the anaesthetic. So for all its risks, by the time we get to the end of the 1860s, the first 20 years of anaesthesia, it's really become embedded as an integral part of the surgical experience, and the painless surgery has been reconstructed as a risk rather than fulfilling a necessary physiological purpose. So thank you. I'll leave it there.
Thank you very much. We're open to questions.
Stephanie, did any of the people who sang the praises of pain during surgery, had any of them been through surgery themselves? Like, did anyone who would ever have surgery without anesthesia ever say anything good about the experience?
Yes, the ones who had it without, not surgeons, no, patients have described it without anaesthesia.
Did they say anything good about it, though?
No, I haven't come across one. I mean, we have very few patient accounts, but the ones that have are very much on how horrific the pain was. And, you know, by the 1840s, there are one or two patient accounts, and they submit to these excisions of a diseased foot or a hand or whatever because they want to have a more functional, useful limb at the end, but the pain is intolerable. So, yeah.
These quotes and descriptions are sort of indirect. They come down to us from the people who are reporting them. And yet, possibly because of the advent of photography, the American Civil War is very bright, and in our minds we're very aware of it all. And yet I don't remember or notice any description of anesthesia, which is well within the dates that you're talking about, the 1860s. Did the Americans have anesthesia? Did they just not use it?
Yeah, absolutely. And I mean, there were real tussles because a lot of the supplies of anaesthesia were blockaded, and there was a real problem about actually how you get supplies onto the battlefield, and that became quite a sort of dynamic of the war. But no, certainly by the time of that, it was accepted that it was something that should be used where possible. And one of the problems, of course, was this sort of risk of fire, because I mean these were very inflammable things. So there was a lot of discussion about how you might sort of minimise that. But yeah, in terms of its use, it was there, and some quite judgments were made about the different sensibility of different fighting parties and things. Again, according to their sort of ability to put up with surgery without anaesthesia if supplies weren't there.
Yeah, I was very struck by the lack of British statistics, because from 1848 on, the French were producing, and the Germans as well, as far as I can tell, because they were quoting German statistics. Were actually had a lot of statistics about this. It's not that anybody questioned the efficacy of anesthesia for putting people to sleep, because it clearly worked for that, but there were a lot of discussions about deaths
I think that's really interesting. There was no one in Britain doing that sort of evaluation. And it's very hard to try and find statistics. I mean, we have averages of sort of chloroform fatalities and things that you can find by the end of the sort of 19th century. But actually, and Snow's practice, of course, is we get his 4,500 cases, and he has one chloroform fatality. So he's obviously outside the norm for that. But it is a very interesting difference for that.
Christopher?
I wonder, you mentioned the use of opioids, and there might be a number of questions you could ask about the opioids and anesthesia. I wondered, for example, if with the discussion of the stimulating properties of pain in surgery had any effect on the use of opioids in before or after surgery, for example? Or are there other kinds of interactions between using opioids and using anesthesia that you noticed when you looked at this?
Pre-anaesthesia, they were sometimes used to sort of stimulate the patient before the operation and then afterwards. So they might be given a little dose in advance to sort of boost them, and then a little dose afterwards. But again, because they're on this sort of continuum of stimulant to depressant, it's judging exactly when you're going to go over to the depressant side. And yes, surgeons start to use them in conjunction with anaesthesia. So, for example, they will be given those after the operation as a way of sort of keeping pain relief for the post sort of surgical period. And that's the thing, you sort of, once anaesthesia becomes established, then the sort of the earlier pain and the later pain then becomes sort of subjects for looking at, and how that can be tackled.
Thanks. I wanted to ask about patient preference and preferences, which you mentioned at several points during your talk. For example, often patients would prefer chloroform to ether. And in private practice, I think the implication to an extent this was changes towards anesthesia were patient-driven, where patients had the freedom to choose, and you mentioned this, which is of course true. But then you also talk about surgeons offering anesthesia to women patients because they're more susceptible to pain, or supposedly, and so on. And so on the other side of patient demand is sort of the question is, well, where does that demand come from, and how, or to what extent was surgeons communicating directly with patients or appealing to them, advertising and so on. So I wondered about that relationship.
Okay, well, certainly with the discovery of chloroform, Simpson himself promoted it. He wrote a pamphlet, he published thousands of copies, and I mean, some idea of the way in which it became sort of part of sort of, you know, popular knowledge was that Simpson discovered this sort of early November 1847. By that December in Edinburgh, in the pantomime, chloroform was featured. So there seemed to be a popular receptivity to it. There were a lot of accounts of operations within, you know, local newspapers, national newspapers and things. And certainly, you know, patients would actually come to the London hospitals and actually ask, I want this, you know, ether or whatever. So there seems to be a very quick public sort of understanding of actually it was there, it was available, this is what it did. But in terms of the sort of risks, that was not articulated so much in those sources. And certainly to start with, I think there was Charlotte Bronte, for example, said that she first read of ether, and her first thought was that she apparently had wiggly front teeth. She thought she could have her teeth taken out and put straight back in, and that would be great. And then she actually started to read accounts of the way in which patients became disinhibited under ether, and she said, actually, no, I wouldn't want to sort of go for that. So I think, and that early period when actually you got, you know, practice sort of developing, but actually through a lot of subjectivity, is fascinating because there's no language to talk about ether when it's first introduced. You know, Snow hasn't done his chemical experiments, so therefore the sort of testaments for actually what's happening have to come from the patient. So when they come round, well, I felt I was going to a black hole, I had a whirling darkness, and then within 6 months, a medical language starts to develop around it. You know, oh, well, the patient went to the 2nd degree, then the 3rd degree, and then it was okay. And so we lose that subjectivity. But no, I think the sort of patient interactions with all this are fascinating, because they do seem to have been, you know, a driver to some extent.
One last question.
Just coming back to this question of women in their tolerance to pain, it's quite interesting because in ovariotomy they say the complete opposite, and they say women can tolerate a great pain, presumably to justify doing the operation. But I would have thought as well with childbirth and things like that, there would have been a conception that women could tolerate pain. So is this something that is changing at this time? Is this to do with a reconceptualisation of women, or is there something broader going on which makes them surgeons think that women have less capability for pain?
I think so, and it's also because the sort of types of operations, these aren't necessarily the sort of major ones, but for sort of tooth extraction, for sort of more minor procedures, it is that females are very sensible, and then they're not going to be able to tolerate it. And I suppose that the sort of history, certainly on the dental side, that's quite interesting, because there are lots of accounts of patients sort of being halfway through having tooth extractions and actually just walking out because they can't stand anymore. And that seems to be very much women that are sort of, framed like that. And then that seems to push that. But no, it does seem a strong part of the argument. But you see, the arguments that are made about females who are not so sensible, Martin Pernick has written about this in the US, and particularly sort of Negro women, and they, in terms of the hierarchy of sensibility. So I think it's probably very much the timing when that hierarchy is being sort of developed and broadening. Yeah.
Can I ask us one question?
Yeah.
Do you think acupuncture will ever find its way into the annals of the history of anesthesia?
Well, I don't
You
know.
don't have to
Yeah,
answer if you don't wish to.
it is interesting, isn't it? It is interesting. You see, mesmerism was trialled in London pre-anaesthesia, and that was very difficult for anyone to get to work in Britain, whereas in India, it was a very successful method. So different cultures and different sensitivities.
Because 30 years ago, a group of surgeons were traveling through China, and we all wanted to see acupuncture, and they would bring in a different site, someone who had insomnia, and he was being helped. And then they brought in someone with Bell's palsy, and that was getting better, but it gets better in any case. And someone else had a bad back, and they sort of put some wires and needles in, and he stood up and straightened out. And then we went into an operating room. There was a woman having a radical mastectomy, and she was drinking tea with a straw. And I said to the interpreter, she must be having acupuncture. And they said, no, this is a high spinal anesthesia, which is a very tricky type of anesthesia because you don't have that much of a gap between when you breathe or your heart stops. So I'd like to thank you very much and the interesting discussion.
Thank you.
Was that